Hello, my name is Brian Allen. I will be the physician that's going to be taking you through this lecture. I am currently the ultrasound director at LSU Emergency Medicine in Baton Rouge. Here to talk a little bit about midline catheters, so let's get started. So let's go over some goals and objectives. First, we'll learn how to identify veins and safely place midline catheters. Next, we'll move on to discussing why we may consider placing midline catheters over more traditional central lines or ultrasound-guided long peripheral catheters. And lastly, we'll go over the steps in properly and safely placing midline catheters. So when we're doing any sort of vascular procedure or trying to identify vascular anatomy, we really have to be able to tell the difference between arteries and veins. So let's go through them. First up, veins. They're usually very easily compressible. Their walls are very thin and difficult to see. They shouldn't have pulsations in them, but they can. With color flow Doppler, you generally won't see any sort of flow through them. Some ways to make this happen is you can have the patient squeeze their hand, you can have them move their wrist up and down, you can take your free hand and actually squeeze their forearm further down from where you're scanning, and this could cause a shift in blood flow that can make the color flow Doppler flash. Lastly, larger veins actually have valves in them. I almost think they look like a bird's beak, but oftentimes they'll open up and hit the outside lumens of the vessel walls. Now arteries, on the other hand, they should be under a lot more pressure, so they're much more hard to collapse. Their walls are much thicker, so they're more easily seen, a little more white. As we kind of already went over, they should pulse. They often do. With color flow, because they have constant shifts of blood, you'll see color flash. That could be blue or red. All kind of depends how you have your probe oriented and how your machine's set up. As we kind of already covered, they shouldn't have any valves in them. So in the last slide, I mentioned using color flow Doppler to figure out which of these structures are arteries, which ones are veins. Basically, this tool is just a way to determine directionality of flow. We've all probably been on the side of the street, had cars or an ambulance was by us, or remember that question in physics in college or studying for the MCAT. Whereas an object moves past us, the sound actually changes. Blood is kind of the same way. It's moving past that transducer and it's changing the frequency of the returning signals the transducer is picking up. So this is great for vascular ultrasound because we can kind of figure out, is that flow in that blood vessel smooth or is it pulsatile? With that color map though, you just have to be aware that on certain manufacturers' machines, you can flip that setting. The big thing to take away whenever you're doing this procedure is just when you're getting images, is it pulsing? Is it not? What happens when I augment it? They squeeze their hand, there's increased flow, probably a vein. If it's pulsing without any movers, probably an artery. So this slide is meant to give you some examples of what color flow Doppler can look like. So let's start with the image itself. So up here in the top left of your view, this is your color scale. Typically it's in blue and red. Just be aware on this G machine, the way I've got it set up, the red is on the top, blue is on the bottom. All I want you to remember, these are two different directions. Don't make it too confusing. So both of these first two images are longitudinal images. It's where you have an in-plane view of that vascular structure. And this little box here is called your color box. When you're setting this up, you want to make it as small as you possibly can for the structure of interest. Here it's opposed to the vein. It's got this thing called angle correction on it, but we don't need to get into that too much. Just notice the difference between the two different colors. And then when you're looking at these two images, the wall thickness is different. Structure here on the image to your top left, that's actually a vein. Notice it's much skinnier. Structure here in the center top, notice the walls are much thicker. This is your artery. It just so happens that the color flow Doppler demonstrated in this image is red, and that one's blue. But again, don't use that to tell the difference between arteries and veins. And then if I turn my probe in 90 degrees, I can get a short axis view. So now I have a cut through two vascular structures. Notice my color box. One's red, one's blue. Just trust me here, it's harder to see, but that's the artery, and that's the vein. But one limitation to this technology is when you traverse a vessel and the blood flow is about 60 to 90 degrees in relationship to your probe, you can actually have this blending of colors. It's because the way the machine's actually calculating the Doppler effect, you get a zero if the angle is between 60 and 90 degrees. And it just blends the colors out like this. And just be aware too, a turbulent flow can show up like this. To correct that, there's some other specialized tools, or you can just move your probe, but just be aware this can happen. So let's do some little play-by-play to help you figure out how you're actually going to interpret that color flow Doppler that I've been talking about with the still images. So to your left, we've got a short axis view of some vascular structures. You'll notice the color box there, those thin little white lines, and we've got three vascular structures. Near field or more superficial and close to the probe, there's two vascular structures. Notice that there's not always color flow going through those. These are our veins. This one more to your left actually has a little valve in it. So what's going on is I'm squeezing my hand, opening, closing it, I'm increasing blood flow through those veins. It's going in a different direction than it's typically happening with the artery. So we get a little color flash with that. Deep to that, we've got our artery. Kind of see there, it's constantly flashing. With that augmenting maneuver, I'm actually causing it to go outside of this scale, so that's why it flashes red. But generally, you notice this is mostly blue, the veins are mostly red, so it's going in an opposite direction of Doppler shift as opposed to the veins above it. Then we can move over to the image to your right. This is a long axis view, so I've kind of turned my probe just 90 degrees. I'm on the same plane or in plane with those vascular structures. Got my color box set up here. You'll notice in the deep part of the image, that color flash is just constantly going. That's your pulsatile artery. And superficial to that, you've got this anechoic structure that doesn't always have color flow going through it. That's your vein. So similarly, I'm squeezing my hand, having a friend squeeze my hand or my forearm, and that's causing that increased Doppler shift. So we're getting some flash and change of flow. So we're being able to demonstrate which of these structures are pulsatile arteries and which ones are veins. So we have on this slide is pulse wave Doppler. When this is useful is if you've used all those techniques that we talked about on the initial 2D image, such as compression, looking at the thickness of the walls, are they pulsatile or not, are there valves, still can't tell the difference, you've gone to color wave Doppler, you're still having trouble just being sure which is which. This is another setting you can use to figure out which one's a vein and which one's an artery. So in the image to the left, I initially set up my machine, get the structures of interest. In this case, I've got a vascular structure in a longitudinal image or in-plane image. And I've clicked another button to start the pulse wave Doppler process. This puts this little roster line on the screen. This is my SV gate. And basically what I'm asking the machine to do is along this axis, I want you to tell me what the Doppler shift is right at that little point where the gate is. When I'm setting that up, I want it to be in the center of the vein, away from the walls, because that's where everything is nice and turbulent. I want to make that gate as small as I can to get away from that turbulent flow. So to make it start, I'd hit that same pulse wave Doppler button again on most machines, and then I get this display down below it. What you see here on the x-axis, this is time, and on the y-axis, this is my spectral Doppler tracing of how that Doppler shift is actually showing up for the machine. So I've got in the center of the vessel, hit the pulse wave Doppler button again, and then I get this nice little tracing here. If you notice, there's not really much of any shift, just one linear line. This would be non-pulsatile flow or a vein. Then some of you more sharp-eyed viewers might notice there's some stuff going on in the background. So I kind of mentioned with the artery versus the vein, sometimes there's a big artery pulsating nearby. The machine can actually pick that up and see that Doppler shift. On GEs, there's some auto tools to where you see a peak systolic and end diastolic value. Don't worry too much about this. Let's get a little too fancy. Let's just focus on vein versus artery. Now conversely, if I shift over a little bit, now I've got an in-plane image of an artery, as seen here on the right, and set up my Doppler gate, I'll get a completely different tracing. So I hit the button again a second time, you'll see these big shifts in Doppler flow. This is showing me a multiphasic pattern. So this is confirmed for me, this is the artery. If I slide back, this is the vein. So now let's go through some actual techniques when we're getting these pictures. There's two major techniques. There's the longitudinal and transverse. We're going to start with transverse. So I've got my partner set up here. He's in sterile attire, of course. Simulation mannequin set up. And I've got my machine in the background. Now we've kind of moved things around a little bit just so we can get you a better picture. But typically you want to have everything set up to where the bed's a nice height and you're comfortable. Your operating dominant hand has your elbow at about 90 degrees. Get a nice comfortable grip on the back of the syringe with your finder needle. And then your non-dominant hand will be gripping the probe. In this case, the probe is the patient's right with the orientation marker. And then you'll want your needle at about a 45-degree angle. Why do we do this? This helps with sound return, and this actually maximizes the amount of catheter that you'll be able to place into the vessel later. If you go too steep, you might kink the skin, kink in the blood vessel, then you won't have very good flow. Go too shallow, the path is so much longer that you'll actually lose a lot of catheter length within the skin. That may cause that to back out later. Now you might be wondering, what do I mean by short axis? You kind of notice with the vessel, this is very short. If I turn 90 degrees to it, it would be all the way across the screen. We'll see that here in a little bit. So in this picture, it's an in vivo picture. We'll go to the anatomy again later. You have the biceps muscle, basilic vein, median nerve, brachial vein, parabrachial vein, and brachial artery. When you're progressing, and again, we'll cover this shortly, your needle is going to start passing through, but one big caveat is you can kind of see this image is very thin. You can blow right past that needle. And we'll go over some techniques of how to avoid that later on. So I'm demonstrating on this slide is basically what does it look like in the transverse technique when I start to pass my needle. I've got a gel model just to practice with and give you a good view. On the top left, we're going to progress from superficial to the top right, a little bit deeper. Bottom left, we're making contact with the vessel. And bottom right, we've actually entered the vessel lumen. So I'm wondering what's happening between these pictures. The big thing is, like if you saw in the last image, I have my ultrasound probe set up, orientation marker patient's right, so I get this nice short axis view. So I take my needle, gently pass it through the skin without going very deep, keep it pretty superficial, and then put my probe, slide back, and locate the needle. So then I'd slide distal to the needle and lose it, and then I advance my needle into my view. So now I'm a little bit deeper. And then I keep progressing that same technique, which is called inchworming. So I'd slide my probe further from this image until I only see this gel model, and then I advance the needle into my view again. So now the needle is making contact with the vessel. So then I'd advance my probe a little bit further along until I lose the needle, and then I'd push the needle forward, and now I've entered the vessel lumen. So now I can look for flash, or I can use another technique with inchworming where I keep pushing that needle into the vessel, keeping it centered, just like it's pictured there, eventually until I'm comfortable with how much needle I have in the vascular structure, and then I can get my guide wire and slide it through my needle to progress along with the procedure. So here we actually have a live action GIF. Some of you may be looking like, why does he keep retracting the needle? This looks weird. So what's actually going on is when the GIF starts, I've located my needle tip here. Then I slide my probe forward, move my needle tip into view, slide my probe forward, and move my needle tip into view. And I keep doing this until I enter the vessel lumen. So let's watch it again. So needle, lose view of the needle tip, progress, move forward, progress, and keep doing that stepwise fashion until I enter into the vessel lumen. So previously I mentioned whenever you get into the vessel lumen, you can actually keep watching that needle into the vessel lumen. I tend to like to do this just because of the way the ultrasound physics work. You can have false projection in that needle tip, and oftentimes you'll find you may think you're into the vessel and you go to pass that wire and everything backed out, and all of a sudden you have to start over again. You don't always have to do this, but this is kind of an insurance policy to make sure that all that hard work you just made pays off. So what you'll see on this GIF is I've got my vessel lumen, and you keep seeing this bright white echogenic focus. That's just the needle tip, and I promise you I'm not just bouncing in the vessel lumen. What I'm doing is with each view, I'm moving my needle tip into my view and centering the vessel. Then I'm sliding down, losing that needle tip view, and I keep progressing where I see needle tip, lose it, bring needle tip into view, slide forward, bring needle tip into view. It's a good way you can actually almost walk that entire finer needle into the vessel, and just make sure when you pass the wire that all that wire will travel within the vessel, so you'll have a successful catheter placement when you get ready to finish the procedure. So the other technique you can use for passing your needle in comparison to the transverse technique is the longitudinal technique. So I've got my operator here in the sim lab, and notice the probe now has gone from that transverse orientation of the probe marker to the patient's right. It's now rotated 90 degrees, and the probe orientation marker is up towards the patient's head. Needle shaft is still in the same position, 45 degrees. That will give us a nice hyperechoic linear structure. We'll see in a little bit. It'll travel down to that longitudinal vascular structure there. Sometimes you'll see some little lines below it called reverberation artifact. But some things to be aware of when using this technique. Notice how the needle could very easily slip out of that couple millimeter wide scan plane of that probe. When you do that, you may not know that the arteries are adjacent or nerves, so you can injure those structures. There's also this thing called tube artifact. So what that is, when you have a circle, that line is only cutting through part of that circle. So I may think I'm dead on center with the vein, but I might actually be over to the side. Either way, this has caused me to slip up, and if the vein is tortuous, it won't line up perfectly because this probe is a straight line and a lot of things in nature aren't. So when you slip up, you could hit one of those adjacent structures and cause some injuries. So just be very careful about aligning your needle appropriately with the probe, and this should be a good way to secondarily place guide needles into venous structures. So now we return to our gel model, and we're going to demonstrate what that needle looks like as we're trying to perform that longitudinal technique or use that in-plane technique. So to your left, we have our gel model with representation of the superficial soft tissues. Got our anechoic vascular structure. Then deep to that, we have more soft tissues. So roughly 45-degree angle, this hyperechoic linear structure is our finer needle. In this example, it's actually just an IV catheter with the needle inside of it. We've entered into the anechoic vascular structure. So once we've gotten our needle inside of the vessel, we'd move over and we'd start introducing our guide wire. And as the guide wire passes through, you can see it entering that vascular structure. Now, earlier I kind of mentioned that reverberation artifact. These are just multiple echoes of that same structure over and over again. This is why I'd almost recommend when you're using that finer needle, you may want to walk a little bit of the needle into the vessel, because the machine can falsely project this structure a little too superficial, a little too deep. Once you get some more needle purchase into that vessel, that ensures you're centered up. When you go to pass that guide wire, it won't accidentally push the needle back out of the vessel, and you accidentally pass the guide wire into the soft tissues. So this is a live GIF file that I've taken from video from my ultrasound machine to show you what those two previous pictures look like as you're doing it live. So we're back to our gel model. Superficial soft tissue structures. This anechoic structure is our vessel, more deep tissues. So you can see this would essentially be my finer needle. So it's passing through those soft tissues, we're piercing the vascular structure. Then we grab our guide wire, slide it through the needle, pass it through the vessel. So now we're ready to remove that finer needle, leave the guide wire in place, and get ready to instill either the sheath dilator or the dilator and catheter. We'll get to those two different kits here in a little bit. So I just included these examples because a lot of times the learners, they may pass that catheter over the wire and then not be sure if they're actually located in the appropriate position. Their peripheral IVs and midlines, you can actually locate the catheter tip, but with your more centrally located catheters, you're not really likely to find this. So you have to kind of just depend on what's being withdrawn from each port or how is it flushing. So up here in the top left, back to our gel model, superficial, deep, round anechoic structure would be our blood vessel. Call this our donut sign because that's the lumen of our catheter floating towards the bottom of the vessel. And then if we were to rotate our probe 90 degrees, we get back in that longitudinal axis. Got our superficial tissues, deep tissues, got our vascular lumen, anechoic vessel. Then we have our tapered catheter tip sitting within the vessel. So if we're worried about did the catheter tip actually get outside of the vessel, or is everything flushing appropriately, we can pull up our color flow Doppler, because whenever we push that flush through that catheter, it's going to change the flow of fluid through there and we'll get a Doppler shift. So you can kind of notice on this example, I put it just distal to the catheter tip. When I flush some of that saline through it, you can see that color flash. So now we know that our contents are staying within the vessel lumen. So the purpose of this slide is just to demonstrate what is my needle tip doing between the two views and kind of give you an idea of how I'm moving between them, or I could move between them, and ensure that I'm not going too deep, and also maintaining views of structures on each side. So it's a mix of both the short axis and long axis techniques. Now there's a product that a lot of people have access to, but not all of us have. It's called a butterfly ultrasound. You can do a biplane imaging where you get both these views at the same time. But if you don't have that ability, you can still rotate between your transverse orientation and longitudinal orientation. So starting up here in the top, back to my gel model. So we'd start a procedure, get our view of the vascular structure we want to access. Then we'd start passing our needle through the skin. Notice it's superficial, so I'd slide my probe forward. So I'm just seeing the gel model without the needle tip. Then I bring my needle tip into view here. Similar fashion, slide my probe forward, lose view of the needle tip, get my view, then push my needle tip into view. So now I'm getting close to the vessel. Slide my probe forward, get my view, and then bring my needle tip and enter into the vascular structure. So in comparison to the long axis, this is where I've kind of completed everything. Each line corresponds to each different transverse image. So again, to go through the steps, let's say I place my probe where this line is, bring my needle tip into view, then I'd slide my probe to where this line is, advance my needle until I can see it, slide my probe to where this line is, bring my needle, advance it forward, make contact with the vessel wall, slide my probe forward, advance my needle into the view, visualize my needle tip, and then keep that process progressing and pass my guide wire. So now that we've gone through how do we get our images, what do arteries and veins look like, how do we visualize our needle down to our target vein, let's go through the structures that we're looking to actually access when we're doing this procedure. So the main important veins I've labeled on this anatomic diagram. First one's the axillary vein. So you can kind of see it over here near the axilla. The main reason I labeled this is you want your midline catheter to eventually have its distal tip somewhere within the axillary vein. Once it progresses past that and in the subclavian, you start to get more into the territory of a PICC, although a PICC has to land over the actual atrial cable junction. So first one below that, cephalic vein, you'll see this in a lot of bodybuilders, especially you also see it in dialysis patients, but typically in those it's a little bit bigger structure, but it can be very small, hard to visualize. So it's a nice straight vein. It's very superficial. There's not any concerning structures around it beyond the biceps muscle. But because it's such a small size, or it can be absent in some individuals congenitally, this may be a difficult one to locate. So it's not always this easy structure that you always find. Next one is the brachial vein. Typically this can be paired with the brachial artery, but it also is usually generally deep to the biceps muscle or brachialis muscle, so you could pierce either of those trying to access it, or the median nerve can be sitting on top and you've got a big important artery sitting in between them. And lastly, we've got the basilic vein. Again, this is another one that's very, very straight. Most people do have it, could be congenitally absent, and generally in my experience they're usually pretty big, so this is a good target, but they also tend to lie a little bit deeper. You also have to get your patient and kind of really bring their arm out and get them really, really supinated to get a good view of that vein. So it could be hard to position yourself in the patient in a comfortable way to find it. So let's get into the structures you don't want to hit with your needle. So in this image, we've got our major arteries. So axillary artery, it's fairly distal, shouldn't be trying to access for midline catheters that far up the upper extremity. So mostly focusing on the brachial artery, more distally along the humerus here. Got these little collaterals. Sometimes you'll see these associated with basilic vein. Brachial veins will be right up against the brachial artery. In regards to cephalic vein, this perforating artery typically is more posterior. So in my experience, I haven't really come across too many of these when I'm trying to place catheters in that cephalic vein. But again, remember to look at the vessel walls. They're thick. The vessels look pulsatile. If you apply pressure with your hand with a probe, those vascular structures compress. And then we use our color flow Doppler to see is there any internal pulsatile flow. So running with these arteries, we have nerves. So the main one's going to be your median nerve. Here along the brachial artery, there can be a lot of other small branching nerves. You don't have to get into all the different names of these. Just be aware when you start more proximally, it can actually look very similar to a vessel, especially in people that are more active, and elderly people this is less so. But you'll have this hypoechoic to anechoic internal structure. That's where we use our color flow again. Do we have pulsatile flow? Do they compress? Generally nerves will not compress. They should hold their shape with compression. So move more distally, they get this kind of little bubbling, honeycombing type appearance where you get hypoechoic to anechoic circles inside of them. You have a more surrounding hyperechoic periphery, and as you slide up and down, that little bubbling can kind of change and shift. As opposed to the muscles, when you're in short axis, you'll be looking at those, and they're almost little tiny white lines that are varying as you slide down the muscle. If you get in longitudinal axis and slide across it, you have these shifting linear hyperechoic lines, and this is all called anisotropy. Just a little thing to be aware of if you accidentally slide over the side. But again, just kind of summarize, we don't want to stick arteries or nerves. Look for that honeycombing structure more distally of the nerves, thick echogenic walls, pulsatile flow, and do things compress. So I put all the images from the last couple of slides side by side, added a couple of little other markers onto the diagram. So with our venous structures, remember, cephalic's going to be more lateral, runs on top of the biceps muscle. Brachial will be more deep, typically paired, running alongside the brachial artery. And then cephalic veins a little bit more medial, a little more deep, maybe a little more hard to access and position the patient. These little green bars, typically where most people start to try to pass their needle. Kind of landmark here is antecubital fossa, just start going proximal to that. Place this little red line just to remind you, when you're measuring for your catheter, you don't want to go past that axillary vein. This is kind of your stopping point. Once you get past there, you start to get into PICC line territory. So then you're the arteries, axillary artery, pretty deep, shouldn't be sticking near here. But kind of in this territory, you have a lot of different collateral branching arteries. Main big red, we're going to avoid brachial artery. Then we got our median nerve alongside the brachial artery. If you get past the antecubital fossa, might go from that round ovoid shape to more like triangular shape. But don't want to stick either of those. And then some caveats to go through. A lot of these structures are actually blended for our dialysis patients. So if you've got someone that is a dialysis patient, be very aware. You don't want to stick these too many times. It could cause some stenosis, cause some issues further along the road for them to be able to make those fistulas or grafts. So try to avoid those at all costs unless it's a life-threatening situation. And then also remember that some of our patients may be surviving breast cancer patients or current breast cancer patients. When they do those lymph node dissections, they may have trouble draining along that area. So they've had that history too. May need to avoid doing these sticks on these deeper veins. So now we're getting back to what do these structures look like when I'm scanning on somebody's arm. So what we're demonstrating here is I've got a transverse view. Orientation marker is the patient's right. So I've got my superficial soft tissues, that kind of lacy appearance. Go a little bit deeper, start getting muscle fascia. So this is your biceps muscle here. Then I've got this round structure with both hyperechoic and anechoic bubbles in it. So this is our honeycombing appearance of our median nerve. So near the median nerve, remember we said the brachial artery runs very close to that. So that's sitting right there. Brachial vein paired. And if I move a little bit more medial, I've now encountered my basilic vein. As we go deeper, we have some subcutaneous fat. This hyperechoic semicircular structure kind of arch right here. That's the cortex of your humerus bone. On the next slide, I'll kind of color these up so you can see what they look like. So now I'll put some visual labels for us to identify everything with. So again, superficially, we have our soft tissues, lacy reticular appearance. Go a little bit deeper. Go below the dermis, got muscle fascia, biceps muscle. These are some of those linear striations that would cause anisotropy. Then we labeled median nerve, honeycomb appearance, round. Brachial artery, if you try to compress it, shouldn't compress without a lot of pressure. Walls are thicker, pulsatile flow with color flow Doppler. Paired brachial veins. Then our basilic vein, a little bit more medial. Go deep. See our humerus down here. Be aware sometimes congenitally this could be absent. When we're preparing to kind of put all this stuff together, we actually were scanning each other and noting some of the anatomic variability between different providers, and you'll see this in patients as well. So we've got another transverse view of the upper arm, so probe marker towards patient's right, soft tissues, got our biceps muscle, so then we have to go through our same stepwise process. Got this structure, if I run up and down it, you may have shifting and honeycombing, so that's our median nerve. Go below it, this isn't live, but most likely brachial artery. Then we've got some edge artifact from this structure above it. So what that is just the sound wave energy's hitting this more dense structure, bouncing all different ways, so it's not getting a good return between there. So it's a little bit obscured, but there's probably vascular structure here. This is likely the brachial vein here. But what is this big guy sitting right next to everything? So this is actually a very prominent basilic vein. And be aware too, when you're kind of looking at all these different groupings, I've had a few patients, at least in my area, where you'll see two pulsatile structures. Each has their own accompanying vein, so you may have duplication of the brachial artery system and duplication of those brachial veins. But let's go on to the next slide so you can see how everything is labeled up and colored and diagrammed out. So as promised, I put some diagram labels for you to see everything a little bit easier. So I'm going to keep going through the same stepwise fashion. Transverse orientation, probe mark to the patient's right. So got this lacy reticular subcutaneous soft tissue, gets more dense, get below the dermis, muscle fascia, anisotropy when you move along this, shifting, so those are muscle fascicles and biceps muscle. Brachioradialis, maybe a little deep to that. Got our brachial artery labeled in red, so you'd want to compress. Usually the brachial vein should compress. Thicker walls, if you put color flow, this should be more pulsatile, could augment. See the brachial veins a little better. Got our median nerve, so as you slide up and down that in a short axis view, you have that shifting, those anechoic to hyperechoic structures that demonstrate that honeycomb appearance. And then a little bit more medial, you have a very large and prominent basilic vein. So now we've changed orientation, so as opposed to the previous image, we've gone from more medial in the patient, slid over on top of the biceps muscle more laterally. So now we've got our reticular soft tissue here, but then we have this anechoic circular structure here. Hyperechoic linear structure is actually just muscle fascia, and deep to that is our biceps muscle, so you can see some of the anisotropy with the different muscle fascicles here. So if I compress, this should squish. So again, people that kind of lift heavy stuff for fun is the way I was taught. They may have more prominent cephalic veins. People with issues of kind of blood flow going back into their central circulation, these may kind of pop out more. But a lot of folks, it may only be as big as my laser pointer. That'll be very difficult to access or get a catheter floated through. But let me just kind of color this out on the next slide, and then we can move on to our next steps in the lecture. So again, previous images, let's compare this cephalic vein here. We're located a little bit more medially on the patient's arm, so biceps muscle kind of round out here, have brachial veins over here, brachial artery, basilic vein a little bit deep to that. So we just roll our probe, keep that probe marker oriented to the patient's right, slide over more laterally. Then we get this anechoic round structure, colored blue here, cephalic vein, deep to that, muscle fascia, and biceps muscle. So you might be sitting here listening to a midline catheter lecture and just kind of wonder yourself, what is the difference between a peripheral IV catheter, midline catheter, or a PICC line or a central line? So let's start off with the more traditional one that we see in our everyday practice pretty frequently, our peripheral IV catheter. So generally range in length from about 1.4 to 6 centimeters. The ones here about 4.8 centimeters. They're not intended to stay in the vessels for a long time. We use a dwell time to kind of map that out. So they're really more for just temporary access. You don't want to keep these in for more than like days. Weeks might be stretching it, months, definitely not. If you're trying to place these with an ultrasound, you have to make sure you have adequate needle length in the vessel, or else you really won't get much catheter purchase. And then anytime the patient moves their arm a certain way, or if you try to push anything through there, it may push that catheter out of the vein, then all that stuff infiltrates everywhere. You don't have that guide wire to help you actually pass these, so that's why I showed you that inchworming technique where you're moving up the vascular structure and trying to place as much catheter as you can before you ultimately pass the catheter and withdraw your needle. And then these are not ideal for deeper structures. Kind of if you go back to your Pythagorean theorem from high school and college, sorry if that's giving you some stress. With those shifting angles, it takes more and more catheter the more shallow you get. So you may only end up with just like barely even a centimeter of catheter in the vein. That thing is high risk for coming out. Also, traditional needles, yes, they are echogenic, but there are specific products in the market where they actually have an increased reflection of sound, so they're more easily visible. So as we're progressing in complexity of IV catheters, now we've got one of those long peripheral IV catheters, except this one has a guide wire that's self-contained. Typically commercially available. You can see this one's about 5.7 centimeters in length. The needles are actually echogenic, so you should be able to see them a little bit better through your ultrasound. They have that self-contained wire, so you can do that cylinder technique where the guide wire is actually passed into the vessel lumen. You can slide the catheter along it to ensure that you don't backwall or pierce the vessel. Got everything to kind of do sterile or semi-sterile technique except for your gloves, plus minus a gown. You can do that if you like. Got everything in here to help secure. Still need some end cap adapters and a flush. That catheter is only a single lumen. I think I've seen some products with maybe multi, but especially with midlines and PICCs, you can end up with multiple lumens, so you can infuse more than one thing at a time. This has got a neat little trick where you take everything out. It's got a self-occluding valve, but our reps don't want us going deeper than about 2 centimeters. Reason being is we go deeper than that, we may not have enough catheter purchase to ensure that when we push things through that or the patient moves around, it doesn't get pulled out. And then lastly, as far as dwell time, these have pretty good dwell time compared to the traditional catheters. Seen them quote some literature where they did a local study where these seem to be functional up to like 13 days after they were placed. So the longer they're in, increased risk of infection, and they certainly can't dwell for as long as a midline catheter or a PICC. So now we're getting more in the territory of the purpose of this lecture. Not too much information on this slide, just to give you an idea of what a midline catheter looks like when you dress it. So let's get into the nitty gritty of what's going on with the midline, what the differences are, and why you might want to do this instead of a PICC or a central line. So on this slide, I utilize my nice chat GPT on my phone to help me spit out some images. The main context I want to take away from these images is just what does a midline look like compared to a PICC line. So when you look at the midline, they're inserted similar places, may have multiple lumens, they look almost the same. That's why on the previous slide you had that sticker that's warning you like this is a midline and it's not a PICC. So that kind of helps you know what sort of medications go in there. But typically a midline will terminate in the axillary vein. It's not supposed to go past there. With a PICC, it's much longer. Will extend down into where your SVC encounters your right atrium. That's the terminating point there, so you can go way past the axillary vein. So with a midline catheter, your typical length be anywhere from 8 to 25 centimeters. A long midline is anywhere from 15 to 25 centimeters. Short midline can be anywhere from 6 to 15 centimeters. Again, for your anatomic placement, typically go in the upper arm, a little bit proximal to the antecubital fossa, and it should not pass the axilla and the shoulder if you're placing a midline catheter. So this is the product that we had available to us when we were kind of setting this whole curriculum up for our residents at our program. So it's the PowerWand XL. This is how the package looks before you open it up. This is just the contents kind of spread out. There's a lot of different manufacturers for different midlines, so the products available to you in your area may vary widely from this. Just kind of big picture takeaway from this one, this particular catheter is not trimmable. It's actually got the dilator within the catheter lumen itself. We'll see how a trimmable catheter looks in the next image. Just to go through some other things you need to add, does not necessarily come with lidocaine and a flush. You may need to get some stuff for your ultrasound, put a sterile probe cover on it. Still need gloves, gown, drape, all those sort of things, cap. This one has a tape measure, even though I said it's non-trimmable, but you can use that tape measure to determine the distance to your axillary vein so you don't cross over in the subclavian vein. And then you've got all your different things to let you know how long it's been in there, warn you this is not a PICC line, and then even something to put on the patient's wrist to warn you that it's not a PICC line. So I was very fortunate. I actually got in contact with a PA that works with our radiology department at our facility. Basically all she does is put in midlines, PICC lines So he's got a lot of experience with that, and she was able to get me a photograph of what their trimmable catheter kits look like. So I'm kind of looking at the situation. She's got all her sterile garb on, and this kit, as opposed to the other one, the dilator in the other kit was inside the catheter. This is a dilator with a breakaway sheath around it. Got a scalpel because we'll actually have to probably nick the skin to pass this sheath dilator. And over here is my trimmable catheter. Kind of see she's taking some scissors, cutting that. One big important thing with these is they actually come with their own stylet or wire, separate from the guide wire that would be contained within the catheter. So you'd want to pull that back after you've measured the distance from your antecubital fossa up the axillary vein, because you don't want to cross over the subclavian vein, and you would trim that catheter to length. But you can see how much longer that catheter is compared to the previous one, so you can get a lot of catheter into that vein, so it's very safe for things to be instilled through it, and they can have a very long dwell time. So this is not exactly perfectly to scale, but these pictures just give you an idea of how much longer even our shorter non-trimmable catheter is than your traditional IV catheters. And one of the big takeaways from that is just depth and length are key to be able to leaving in a catheter for longer and for patient safety. A lot of times those short peripheral IVs are dislodged within 24 hours. You actually need about 2.75 or so centimeters of length of catheter in the vessel to have a good, reliable, functioning catheter that's not putting the patient at risk of any sort of infiltration of contents or having the catheter being pulled out quickly. So now we've kind of covered midline catheters a little bit. You might be sitting there wondering, well, if I want a longer catheter and something that's safe for the patient, why don't I just put in a central line? You, of course, could. It gives you a lot more lumens typically. Luckily, ChatGPT came to my rescue with this awesome image on the side, but big things to kind of take away is a midline catheter is more cost efficient than a central venous line. Midline catheters have less risk of some complications associated with central venous lines. For instance, I'm not getting anywhere near that patient's lung when I'm placing these lines, so there's no risk of pneumothorax. If I accidentally pierce the brachial artery, not as big a deal if you have to call it a vascular surgeon. If I pierce and dilate the carotid artery, you're in a little bit more of a pickle. And again, some medications still would likely be more safe and are more approved for a central venous catheter, but you can do some of them through a midline catheter, and we'll go over some studies where they actually challenge that notion, and we'll see what they said. So in learning about midline catheters, something that may come up is questions of this product, of just how does it work? How long can we use it for? Is it better than others? So this first study that I found essentially is just looking at how long can a midline catheter stay in that vessel and still be useful. So in this study, they had 82 midline catheters and 50 PICCs at a tertiary academic care center. IV therapy through midline catheters is safe for about 14 days versus months for PICC lines. There's limited evidence for use between 14 to 28 days. So the study did include outpatients and was used to look at feasibility of giving antibiotics to outpatients. So this could be a good way to kind of go to your administrators and be able to prove to them that this is a catheter that could prevent hospitalizations and maybe save them some money. So in a previous slide, I already kind of covered when you place these lines, you may be able to use some medications, may not be able to use others. Again, you should stay within the boundary lines of what your hospital pharmacy approves and what your guidelines show. But in this study, they actually looked at, can we use pressors through a midline catheter? So in this study, there's about 248 patients. They received vasopressors via midline catheter. The median time they stayed in the vessels and were still used is about 14 and a half days, give or take about 12.88 days. The average duration of pressure infusion was anywhere from 7.8 plus or minus 9.3 days. Some of the medications used were norepinephrine, epinephrine, vasopressin, phenylephrine, and angiotensin II. And what they didn't see were any significant complications related to drug delivery or limb endangerment. So let's circle back to that question of what can we actually put through these midline catheters, and why may you still want to use a PICC or a central line to administer medications through a more central route. So some things you may have to stop and think twice about are TPN solutions or medications with a pH of less than 5 or greater than 9, with their very high osmolarity, such as greater than 500 milliosmoles per liter. So these would be kind of your nutritional fluids and things like that. There's also the vesicant drugs. These are your big chemotherapy drugs, the substances that cause tissue blistering. Examples would be daunorubicin, doxorubicin, etc. So these big catheters being placed in these veins, you may start to wonder, is blood flow being restricted or obstructed? And that could lead to blood clots being formed. So that's one question they sought to answer in this study. So the total amount of catheters in the study was 439. These are in 430 patients, so 9 of those patients had 2 midline catheters. The average age was about 68. The median time that these catheters were staying in and being used was about 10 days. They found symptomatic thrombosis in about 20 patients, or about 4.5% of the overall study population. Where did they see more clots in? It was mostly in males and placement in the cephalic vein. So just remember, whenever I point out the cephalic vein, it's very small in diameter, so that catheter may obstruct a lot of flow going back towards the central circulation. And it's one reason why I think they were seeing increased blood clots in this study. So one of the things that a lot of hospital systems will look at when we're replacing these catheters is how often we're seeing infections. These are rates or metrics they may track. So that's a big question. Is there any advantage of midline catheters over our standard peripheral IV catheters, such as the long ones that I talked about earlier? So basically compared these midline catheters with ultrasound guided long peripheral catheters in 185 difficult vascular access patients. So the incidence of catheter-related bloodstream infections are about 0.72 of 1,000 catheter days for the long peripheral IV catheters, about 0.48 of 1,000 catheter days for the midline catheters. So their overall conclusion were midline catheters allow for longer uncomplicated indwelling times than long peripheral IV catheters. So another question you might raise is, what is the utility of putting these catheters into patients that are critically ill in the emergency department? So I was fortunate that one of the co-authors on this study actually participated in the one we're talking about here. So in this study, they placed 403 midline catheters. Amongst these catheters, 187 of them had a single lumen, 213 were dual lumen. As far as placement percentages, 47% were in the basilic vein, 32% were in the brachial vein, and 15% were in the cephalic vein. Why did they put these in? In patients that need both IV access and medication administration, that was about 39%. IV access alone was about 26%. And the need for IV access, medication administration, ongoing resuscitation was about 17%. They had a 99% successful placement. The median number of attempts was 1. And the range of number of attempts was 1 to 3. So 64% of the time they're successful on their first pass. 13% of the time they had to go on to a second pass. And 3% of the time they had to go on for a third attempt. So I'll keep going over some details from that study. Essentially, we got a table over on the side there. It'll list some of the insertion complications, insertion-related complications, and dwell time-related complications. I'll let you go ahead and read through those different items and the numbers associated with them. But big thing here is the median days the catheters remained in place was about 5 days, ranged from about 2 to 8. And while it was in place and functional, the median time was about 6.7 days. It's ranged from 1 to 48 days. So there may have been some outliers that skewed those numbers a little bit. The overall conclusion are midline catheters may present feasible alternatives to central venous lines in critically ill patients. This was, again, a single center that did this study, so they did suggest further research was needed, just in a multi-center approach, so we can make sure these numbers sync up for everybody in different regions. All right, so now that we covered all this stuff regarding how to use the ultrasound to find veins, arteries, identify structures you want to stick, which structures are we trying to stick, and the difference between a peripheral IV catheter, central venous line, and midline catheter, let's get to the actual process of how you go about placing one of these. You'll notice the first bullet point stating that you need to obtain informed consent. This could vary from center to center, so just check with your administrators. A lot of times we put in catheters, and our nurses do as well without getting that, but this should be a sterile procedure. You're having to do a lot of work for it. They may actually require that to be done, but again, just check, make sure you're not getting on the wrong side of anyone. But we would get that from the patient, the surrogate. Then we get the patient placed in a nice comfortable position, get the machine to where you're not having to look side to side. You're comfortable. You're at a nice height with the patient's bed and yourself to where you have your arms in a nice neutral position, usually bent about 90 degrees about the elbow. And then we can kind of determine which direction we want to use, transverse, longitudinal. And we'll keep the process going on the next slide. Okay, so now that we either have or had not had to obtain that informed consent, depending on your actual protocols in your institution, we need to get the patient set up in position so they're nice and comfy, you're nice and comfy, you're not bending over your back, your arms are in nice comfortable spots, they're not going to fatigue, the machine's in a good sight line, so you can start assessing the patient and determine which vein you need to stick. So the probe of choice for this would be your high frequency linear probe. With your tourniquet, you want to actually take that and place it up in the axilla. Some studies have shown that will have the highest success rate with any of these ultrasound guided catheter procedures, at least in the arm. And the ones that we want to target, proximal to the antecubital fossa, or the basilic, brachial, or the cephalic. And again, we may need to just kind of traverse it, see the length, at least with our non-tremble catheters, make sure we're not going past the axilla. The tremble, we can kind of measure that out too. And then once we get ready for the next step, release that tourniquet so we're not starving that patient's arm for blood because it's just backing up. And then we'll take a paper towel, wipe any excess gel, and then further sterilize it with these wipes. May be different, but this is a good product. It's fairly safe on all manufacturers as far as I can tell, and it's actually good for even some viruses that some wipes don't cover. All right, so let's move on to some pre-procedure prep. So once you've gotten away from the patient again, you'll go over to a sink. You want to wash your hands with soap and water, dry them off real well. And then we'll go and grab that tourniquet and some extra gauze just to make sure we get all that ultrasound goop that we left behind off. Put the tourniquet up, and then we'll take our chlorhexidine gluconate stick, crack it, make sure that everything's flowing. And then you'll basically want to wipe on the patient's arm from just distal to the antecubital fossa all the way up to the axilla. You want to cover a pretty broad range just in case during the procedure you have to switch locations if you have any complications or problems. That's already good and prepped for you. All right, so now that we got ourselves cleaned up, have the patient cleaned up, let's move on to the next pre-procedural step and how we prep for our procedure. So this is going to need full barrier precautions. So you want to get a cap, some sterile gloves, a gown. You want to drape the area with a sterile drape. You'll need to get that separately from most kits. And then place the fenestrated drape within the inside of the fenestrated drape. And you can see my partner here. Once you place it around the area where you determine that your target vessel is going to be, you want to take that swab and actually swab within that area again. And then you want to have an assistant help hand you the ultrasound probe so you can place that sterile transducer cover and set some sterile gel on your field. And you want to do a timeout to make sure you have the right location. Rescan within that re-prepped area where you put your fenestrated drape just to make sure that the vein you intend to cannulate is still in that location. And then you want to grab your lidocaine and nest the site where you plan to stick them. So then taking a stop and just making sure we've got each kit discussed and we're setting up everything appropriately. Let's take a trip back to that trimmable IV catheter. So even with the catheter and dilator within themselves in the first kit that I showed you, there is a tape measure, so you can kind of figure out the distance that you're working within. But with these trimmable catheters, like I said earlier, you kind of see that you've got this port and this cap that's removed. Oftentimes this cap or a cap may come with a kit where there's a stylet or wire that helps stiffen the trimmable catheter. So before you go and trim it, measure the distance from the antecubital fossa up the axillary vein, and then you measure that out on the catheter, but you want to withdraw the wire or stylet back so that when you go to trim it, you're not accidentally slicing through that wire or stylet. So now we've got everything set up, ready to go. Let's start the actual meat and potatoes of the procedure, if you will. So just a little asterisk here, when we were taking these photos for this talk, I wanted you to be able to see where the patient is positioned and where the operator should be positioned. So typically you'd have your fenestrated drape. I'm usually a little bit further down, but it depends on the patient's anatomy and what vessel I'm aiming for, kind of draped over. And then you have your opening within that broader area, so you have plenty of room to work around with your ultrasound probe. You have your sterile probe cover over the ultrasound itself. And then you'd have this machine a little bit more in front of you. This is just so we could demonstrate everything at the same time. And you'd have the drape over the patient's arm. Some stretchers have the ability to possibly maneuver out so you can put their arm on it. I often actually grab a little bedside table and place it right at the same level as the patient's arm and have them extend it out, place it there, and then put the drape over it. So when you're kind of leaning into them, you're not contaminating your sterile gown. So we've got our transverse orientation probe. So we have our short axis technique. Or if you're more comfortable or you have a better view, you can use that longitudinal orientation or the in-plane technique to begin sticking your vessel of choice. So now we're starting to pass our needle, and we have our two main techniques to do that. You can either do one or the other or a hybrid approach. So the top image, this is our short axis technique where we're in transverse orientation. So we pass our needle tip through the skin, move our probe over it and localize it. So every time we move that probe, we're moving the needle tip into our field of view. You want to keep the needle about an optimal 45-degree angle and keep traversing down where you lose sight of the needle tip, bring the needle tip into your field of view until you actually access the vessel lumen. Some ways to tell you that you have done that is if you don't have a syringe on the hub, then you'll see some blood flowing back into it. If you do have a syringe on the hub, you will see some blood flowing to the syringe. One thing is if you don't have the syringe on the finder needle, you'll need to finger occlude the hub of that finder needle so you don't get any air embolization before you pass your wire. Conversely, you also have that in-plane longitudinal technique, This one, you want to maintain visualization of that needle shaft throughout your procedure. So if you kind of drift one way or the other, you might run into one of those arteries or nerves that are adjacent so you can't see them. Once you puncture the actual vessel lumen, same thing. Make sure to occlude the needle with your finger if you don't have a syringe on it. If you have a syringe, the blood will flow back and flash. Then you would remove the syringe and pass your guide wire through the finer needle. It's like we talked about on the last slide, once your finer needle has entered the vessel lumen, you want to either finger occlude it if you don't have a syringe attached to that hub. And that's to prevent any sort of air embolization. If you do have a syringe attached to the hub of the finer needle, you want to remove that and then again finger occlude the finer needle. Next step, you grab your guide wire. You'll notice on both ends they're a little bit different. There's a stiff end on one side, and on the other, it's still straight tip, but generally it's soft and very malleable, meaning it'll kind of flop around. So you'll get that soft, malleable end, and that's what you're going to pass through the hub of your finer needle. Now, what does that look like once you get down through the ultrasound? If you want to watch, you can have your image. It's passed through. And again, we have that hyperechoic guide wire with reverberation artifact behind it. So progressing from the previous slide, now where you'd likely be is the finer needle still within the patient in the vessel, but the guide wire has been placed. You still maintain control of the guide wire and take your hand that's not maintaining control of the guide wire and slide the finer needle over the guide wire out of the skin while you maintain control and constant grip of that guide wire. So then we grab our catheter and stiffening stylet / dilator product, at least in this non-trimmable device. So if you notice the two pictures, this is how it would come out of the bag. You still have this end cap threaded over the hub of the catheter, but just whenever you get ready to remove everything, remember you have to unthread it. So now we're looking at the patient, they have the guide wire in place. You take the guide wire, place it into this distal tip to where the stylet / dilator would be protruding, and then we would thread that guide wire up through the stylet and dilator and catheter, and it would go through this tube here, and it would exit out of a little hole in the top of that yellow cap. So then we would slide that unit over the guide wire with one hand while we stabilize the guide wire still until we almost get to the skin. So you can either have placed the biopatch before you slide that unit as one over the guide wire, or you can slide it just prior to the skin, put the biopatch on there and continue and progress and slide it all the way to the hub. So now you're looking at the patient, you've got this as one unit all the way down to the skin, your biopatch in place and the guide wires still coming out. So what do we do next? So to start, you would actually unthread that yellow and blue cap from the hub of the catheter. And you would take your hand that's gripping the guide wire, still have control of it, but also grab that cap. You want to take your other hand, stabilize the hub, and remove the stylet / dilator and the wire as one unit out of the catheter while you stabilize against the skin so it doesn't come out. And once the guide wire and stylet come out, then you would finger occlude the end of your catheter. So I kind of wanted to reiterate the last steps that we talked about on the last slide just because it really tripped up some of our learners. We had them go through this before the educational component. But just with this product, you can see it comes as kind of one unit. It's got this little indication here for the max flow rate. So you may want to check with your radiology department at what they run the CTAs at. In our facility, it's about 4 to 5 milliliters per second on our max volume CTAs. This one would be just fine since it's 8 milliliters per second maximum. But oftentimes they'd try to be setting this up and they'd go to put the extension set or kind of evacuate the air out of it, and they would be putting the flush up against that hub. Whereas what we talked about is kind of once the wires through this whole thing as a unit, you unthread that cap, stabilize the catheter, remove everything. So you can either have a pre-flushed extension set with your end cap adapter on it, or you just have everything set up, you attach it, and then you can get a flush, pull some blood back, and then flush everything home to clear it out. So like I mentioned a couple of times, there's going to be some variation in how manufacturers have engineered stepwise processes to get these catheters safely into patients. So with that Trimble product that we mentioned earlier, they'll often come with a dilator within a breakaway sheath. So this is kind of my cartoon version that'll appear in some of these other slides of this device, but you have this blue tip that's actually the dilator, and this black component that's riding up with these wings, that's actually the breakaway sheath. We'll also need this scalpel to help pass that to the skin. But if we backstep in our procedure steps, so we have the finer needle and the wire in the patient, we would remove the finer needle and leave the guide wire in place so it's in the vessel. So we grab our scalpel, make a small little skin nick, right adjacent to the wire. And remember, a lot of these vessels are only a centimeter and a half from the surface of the skin in most patients. So we don't make a big deep cut because we can easily injure something that's deep to those tissues. Once we made our cut, we grab our dilator and sheath device. Then we take the wire, feed it through the distal end till it comes out of this yellow cap, and then we grip towards the distal end of the dilator. We have one hand stabilizing the wire, the other one passing the dilator and breakaway sheath. We go to that nicked area of skin and begin to slowly pass it down into the vessel. So we get it all the way to the hub with the wire protruding from that yellow cap. So next, we still have the wire stabilized. We unthread this cap in a counterclockwise fashion, and we'd actually remove the wire and the dilator as one big piece. So once that's all out, you'll actually want to finger occlude that sheath and hold it in place. And again, we're going to back up, but remember, we've got that catheter with the wire stylet in it, and now we want that wire stylet just protruding from the trim piece that we made earlier. So now in our process of this trimmable catheter product, we still have the patient, and we've got this sheath all the way to the hub with the wings protruding, and we've finger occluded that sheath. So then we grab the distal end of our catheter with the wire or stiffening stylet just protruding, and we start slowly feeding that through, down through the sheath into the vessel. So we'll continue that process, stabilizing the sheath, passing the catheter, until you have just a couple inches or centimeters of space between the hub of the catheter just before the lumens and the portion of the catheter that's entering into the sheath. So now you'd be looking at this device to where you have a combination of the sheath, hub of the skin, small amount of catheter coming out of the sheath, the remainder of the midline catheters, hub, lumens, and ports toward the back end protruding, and you might wonder, how do I get this thing out without backing out the catheter? So that's where ChatGPT helped me make a little image to demonstrate it. But you've got these wings, so you grasp both sides, you can kind of see they're textured so you can get a better grip on it, and you'd pull your hands apart in an east to west fashion. You'd actually begin to split it. So you can kind of see where it's pre-cut, but it'll start to split. So then you want to stabilize the catheter, and as you're slowly trying to feed the catheter, you're going to be backing out that sheath. It's almost process, you just back out a slow amount, just a tiny amount, while you're stabilizing the catheter, feed it through the sheath a little bit, and then external of the skin, you're going to slowly peel away this breakaway sheath. So you're going to keep doing that in a stepwise fashion. I'm just passing the catheter a little bit, removing more of the sheath, and then peeling away more and more of that sheath. You're going to keep going until the sheath is completely out and split away from the catheter, and then you would advance the catheter all the way to the skin surface. So again, to reiterate, we've gotten to the point essentially where you're slowly moving the sheath and catheter in a stepwise fashion while you peel the sheath away. You've gotten to the point now where the sheath is completely broken apart from the catheter and has been removed. So you would advance the entire device until that hub that's just past the catheter portion gets all the way to the skin. So this is where you try to put your biopatch, and then you can go to the part of the lumen with the hub, untwist the cap, remove the stylet or wire that's internal to it, and then with each of the lumens you would want to place your caps, and then most likely withdraw some fluid, being blood, and then flush some saline back through to clear it. And then you would progress to finally securing and finishing the placement of your midline catheter. So for the final pieces to the midline catheter puzzle, when you're replacing that biopatch, just make sure to clean up any excess gel or blood that may have come out as you're replacing it. But you've got your biopatch ready to go. You've got all your extension sets hooked up to each one of those lumens that are coming from either product's hub, either the non-trimmable or trimmable catheters. And you've got your end caps in place and you've flushed everything clean. And then we'll progress to see either if you're unsure how to make sure that the catheter is still in the right place, and then finally kind of tacking everything down and getting it secured. So for this step, I'd really just say it's only necessary if the operator sees fit. And a lot of time with learners, they've kind of gone through this whole process. They might have been real nervous. They're not sure of themselves. So I'm sure they pulled some blood back from some of those lumens. You think it should be functioning, everything flushed just fine. But if you want to give them some confidence or just want to double check that everything's in the right place, if you've got enough visualization, you can go down to the distal end of the catheter. So you should have measured about where that should have gone, or you have maybe an 8 or 10 centimeter non-trimmable product, which shouldn't be too far from wherever you placed it. You can go down to the distal tip. Then we can either use our short axis technique again. So we're visualizing the anechoic vessel with our little donut sign, showing the catheters within the vessel lumen, or you can get an in-plane view and see that tapered tip within the vessel lumen. So again, this step isn't always absolutely necessary, but with novices or people that haven't done this as much, they may have some nervousness about if they place everything correctly, or maybe in the process of trying to secure it, you may have noticed things got pulled back or slightly dislodged. So you can go down to the distal tip of your catheter, start visualizing everything. And so you can see in plain view, got your tapered tip. You can get a flush, have someone or yourself connect it to the end of the extension set on that end cap adapter. And you can push some flush saline through with your color flow Doppler, see that flash, make sure it's in the appropriate vessel. Now we don't see it here, but another thing that could have happened, like let's say if you use that in-plane technique, is you could have accidentally slipped into an artery. Now a lot of times you may see that pulsatile blood flow coming up, and that would be concerning. Or if you kind of look and you're like questioning, is that the valve or is that the vein or artery? You can actually go and attach an arterial line transducer to the extension set and see if it's got a waveform, or you can pull some blood and get an ABG. Hopefully you don't have to do that, but just in case you encounter that situation, that's one way you can verify that if you're unsure if you're in an artery or a vein. So we're at that point where we're positive the catheter is in the appropriate place. It's protruding from the skin. We've cleaned up all that excess gel, ready to put our biopatch down. There could be some variations depending on what your kit contents are. But on this photo that's done in our sim lab, these are some of the contents you may see. So this is our non-trimmable catheter. It's got this specialized stat lock, as they call it. It's where this blue clip has some blue arrows. So when you go to attach it to the hub, it should be oriented where the arrows are in the same direction that you intend for any flow to go through it. They've got these little backings, so this is almost like a band-aid. Got some alcohol prep pads, skin protectant, and it almost acts kind of like primer. If you ever painted something, so you put that on the skin and it helps the adhesive grasp the skin a lot better, especially when you put that tegaderm down, because if you haven't got all that gel and everything up, you want to clean up the alcohol, do a wide swath over this arm so that then this device, when you go to secure it, will stick really well. When you put the tegaderm on top of it, that will also adhere very nicely to the skin. So once you go up to this device, you get that clip set in place. You'd start peeling everything back almost like it's a band-aid to get it to adhere down to the skin. Do that on both sides. Then you get your tegaderm, peel the backing off, stretch it over the entire area, kind of let the extension tubing sit from that opening. It's also got this little piece that we had forgotten to put on when we were setting up this demonstration. That's okay. So this little area here with that recess in it would tuck up right against the hub. It would help secure everything down, kind of make a nice little circle with some pressure back on that catheter hub. And then we'd have our extension set with our end cap adapter. And you get your sticker just to warn everybody, hey, this is not PICC line, it's a midline. And then also to let them know if they go for any contrasted studies, what the maximum flow rate through that product is rated for. So for the final step, for some post-procedure cleanup, should be obvious, but just to remind you, your kit had a lot of sharp things in it that shouldn't go in the normal trash can. So grab all your needles, the wire, anything that shouldn't go into a typical trash can, place that in there, get all the other trash, put it in either the red trash cans for possible biologic waste or biohazards, and then get the non-biohazard stuff, put it in the regular trash can. So then you would go up to your ultrasound probe once that's all been done, remove the sterile probe cover, and then clean up all the gel that was underneath the sterile probe cover and get your ultrasound wipes and clean everything up on the ultrasound probe. All right, so let's wrap everything up. So with the first point, midlines can be a superior choice for difficult IV access in the ED. So we have those traditional peripheral IVs that really aren't long enough to give us those key parts of length of catheter in the vessel to keep it from coming out. And then compared to central lines, these may be more cost effective, and they can almost have just about all the same things placed through them. In the ED setting, we're probably mostly using vasopressor therapy. I don't think many people are placing TPN or putting chemo in the ED, so we don't have to worry about those too much. And then we're going to actually use our different techniques to place these catheters. It's a good idea to get comfortable with multiple techniques so that if you encounter any challenges, you can traverse them pretty easily. So we've got our longitudinal transverse techniques to be able to place the finer needle down into the vessel. And we go through different steps to get our tremble or non-tremble catheters into the vessel, secure everything. And then if we need to, we can go back and actually check the placement by using our color flow Doppler, just visualizing the catheter in the appropriate vein. Or if we got into trouble and there's some concerns about an arterial puncture, we can use those steps like placing up to an ABG or getting a arterial line transducer and see if it's got an arterial waveform. And lastly, to be a good citizen of the ED, just make sure to consent your patient if it's necessary. Take your time out before your procedure. Be clean with all your precautions. Wash your hands. Put on your cap. Put on your mask. Go on your sterile gown. Get your sterile gloves. Use sterile drape. Make sure you have plenty of CHG sticks to be able to appropriately sterilize the skin of your patient and keep everything clean. And then once you're done with everything, just make sure to put your sharps in the appropriate receptacles, and then put the trash in the appropriate places and get the room nice and clean. Your patient will thank you and your nurses will love you. But I very much appreciate your time. Hopefully this was helpful, and good luck with any catheter placement if you decide to do this at your facility.